My name is Dr. Miguel Silva. I am the bariatric site director at Lawrence. Our program has been at Lawrence Hospital for close to 19 years now. You'll be meeting and hearing from our bariatric surgeons, Dr. Arpan Goel and Dr. Makram Gideon. You'll also learn about our hospital and our team, obesity and its consequences. The surgical treatment options will be discussed in detail, outcomes, weight loss, and complications associated with each procedure, and what the next steps will be. Our clinical team, you will be hearing from Dr. Goel and Dr. Gideon, who will be hosting this seminar, and you will be working with Danielle and Lucrecia, who are our registered dietitian and nurse practitioner, who will help you through our program and through your journey. We have 2 office locations, one in the Bronx and one in Bronxville. And I will now have our surgeons start explaining our program to you. Thank you for joining us.
Hello, my name is Makram Gideon, and I'm happy to talk to you about Lawrence Hospital Weight Loss Surgery Program. Our hospital is a 288-bed facility that was founded in 1909. We have a patient-centered bariatric surgery team. We are part of the NYPH, and we are affiliated with Columbia University. Our program is ACS and BSA-QIP accredited as a comprehensive center, and this is since 2015. What it means is that we've been peer-reviewed and we meet rigorous standards for quality and safety. What about obesity? What's the definition of obesity? Obesity is defined as a condition where fat accumulates abnormally in tissues to the extent that health is impaired. It is considered a disease and stemming from multiple environmental and genetic factors. The measure of obesity is measured by looking at something called the body mass index, BMI, which is really a ratio of your weight to height. By looking at this weight to height ratio, we are able to assess how severe the problem is. The normal range of the BMI is 18 to 25, and anything above that is considered overweight. You have the obesity class 1, BMI above 30, class 2 above 35, and class 3, BMI above 40. Obesity is a pandemic, and if you look at the United States map and it's color-coded by state, prevalence of obesity per state. Some states have obesity rates of 30, more than 35%, less than 20. Though this is from 2011. If you, as time moves on, the problem is getting worse. 2015, 2019, you have states that have more than 40% obesity. This is from 2020. This is important. Obesity affects every single organ system in the body. In the cardiovascular system, you can have hypertension, congestive heart failure. You could have a heart attack. Pulmonary system, you have obstructive sleep apnea. You can have worsening asthma. Metabolic, we're talking about association with diabetes, high cholesterol, musculoskeletal, we're talking about low back pain, knee pain, and so on and so forth. Even the risk of cancer is increased, and this is thought to be related to increased inflammatory component that is associated with obesity. When you combine all of those things together, the risk of dying increases with an increasing BMI. For example, if you look at the normal BMI, 20 to 25, and the risk of death is 1, as you increase the BMI class, the risk of death increases. It's 2.5 times for a patient who has a BMI of 35. This is why you're always encouraged to lose weight. Your physicians are always on your case to lose weight. In terms of the treatment, it starts with prevention, of course, with all education done on exercise, on proper eating, lifestyle modification, diet and exercise, as well as pharmacologic treatment, meaning medications. Do actually work. The problem is that the amount of excess weight loss is not as much as you would like, and the effect is not sustained on the long term. And so this is why surgery becomes plays a role. This has been proven a long time ago. If you compare patients who diet and exercise to patients who have surgery, in this diagram, this is a study that divided patients into two groups. One group that dieted and exercised and were followed for 10 years, and another group decided to go for surgery. The group that did the diet and exercise lost a little bit of weight, but then regained at 10 years, as compared to the group that opted for surgery. They lost a significant amount of weight, regained some, but then remained less heavy than they did at the start. And this is at the 10-year mark. If you look at the breakdown of bariatric surgeries done in the United States from 2019, for example, 250,000 operations performed. Of those, the breakdown is the following: 60% sleeve. So the sleeve gastrectomy is the most common operation performed. 20% is, 18%, excuse me, is the gastric bypass. Revisional operations, 16%, and the rest is, different operations, including balloons and whatnot. So the question that comes to mind: am I eligible for surgery? To be eligible for surgery, you have to have a BMI more than 40, or you have to have a BMI more than 35 with a serious medical problem that is obesity related. You have to show commitment for surgery. This is by showing adherence to the pre-operative workup. And you should have attempted non-surgical weight loss methods. I'm talking about medically supervised dietary visits. So what are the different procedures that we can offer? We're going to be first talking about the sleeve gastrectomy, which, as we had mentioned, is the most common operation performed in the United States. Then we're going to be talking about the Roux-en-Y gastric bypass, which is the operation that has been done actually for the longest. Next, we're going to be talking about the SADI, which is the newer addition to the armamentarium to treat obesity. This is the newest procedure endorsed. We're going to be covering it also a little bit.
My name is Dr. Goyle. I'm one of the surgeons here at Lawrence Hospital. I'm just going to talk to you a little bit about our program. The first operation I'm going to talk about is the sleeve gastrectomy. In the sleeve gastrectomy, we take out approximately 80% of your stomach, leaving you with a sleeve of stomach left. By doing this, you decrease the amount that you can eat, and therefore you feel a little bit full faster. It also, in certain people, it does also decrease your appetite. And the reason why is because a lot of the cells that cause hunger have been shown to be in the portion of the stomach that we remove. Now, it doesn't happen to everyone because those same cells are located inside the brain, and sometimes those take over and you don't get that same effect. We usually see about 65% excess weight loss. Now, I'm going to stop here for a second. Excess weight. You calculate your BMI, the weight that you would be to be a BMI of 25, and then the amount, and then the weight you are now, and you subtract the two. That's your excess weight. So your sleeve gastrectomy would help you lose about 65% of that weight. And usually it's over about 1 or 2 years. The weight loss with the sleeve gastrectomy tends to be a little bit more steady. Usually we see about 1 to 2 pounds per week. All of these procedures are done with the small incisions. They're minimally invasive. And that's the only thing we really do at our program. As far as the amount of time off that you need, everyone's different, but the average is usually you stay overnight. You stay in the hospital for about 23 hours, and then we usually send you home, and we ask you to stay home for about 2 weeks, depending on the individual patient. So the advantages of the sleeve gastrectomy when it comes to the actual procedure itself, it is, from our standpoint, technically simpler operation. It can be performed in patients who are a little bit higher risk. And sometimes patients end up needing 2 operations. And so the way we found out about this procedure is this was used as a first step before getting, for example, a gastric bypass. If for patients who are planning on getting a second operation afterwards. The complication is less than it is with the gastric bypass because of the technical aspects of the procedure. And so that's why, as you saw on the previous slide, it is one of the most popular operations for bariatric surgery. Now, not everyone's a candidate for the sleeve gastrectomy. There are disadvantages with the sleeve gastrectomy. First off, that portion of the stomach that we take out, it's out for good. We cannot put it back in. It is taken out of the body. And therefore, this procedure is non-reversible. Once we do the procedure, then that's all we can really do. Now, there are other surgeries in case there are complications to help fix this. However, we cannot restore your normal anatomy. The big one is reflux. We do ask everyone about reflux when they're planning on getting a sleeve gastrectomy. And the reason why is because if you have significant reflux, this can get worse after a sleeve gastrectomy. 2 out of 10 people who actually don't have reflux will actually develop reflux after the procedure. Now, this can sometimes be as mild as just being treated with medication, but sometimes it can be very severe and require more. When you compare it to the gastric bypass, there's less of a metabolic aspect of it, and that's why the gastric bypass is better when it comes to really bad diabetics. And all the procedures require a change in your lifestyle after the 18 months or 2 years, or even immediately after surgery. And the reason why is because there's nothing that says you will keep all that weight off. It is very possible to regain all your weight after any of these procedures. And so the big part of any of these procedures is a lifestyle modification. Once you lose the weight, we need that lifestyle to change so that we're able to keep that weight off. And we are available to you. We will be following you lifelong to make sure that we can help that out.
What about the gastric bypass? The gastric bypass is the operation that's been performed the longest, close to 50 years now. In this procedure, the stomach is divided, the intestine is divided, and then the intestine is rewired towards the pouch. It is done minimally invasively, either laparoscopically or robotically, and then you stay in the hospital for around 23 hours. You stay off of work for 2 weeks. The way it works, you are able to eat less food, so less calories are ingested. The food that is ingested bypasses the absorptive part of the intestine, so less calories are absorbed. And then there are hormonal factors that lead to less hunger and more fullness. The advantages of the operation is that it causes sustained weight loss. Approximately 75% of your excess weight is lost over 1 to 2 years. The technique of the gastric bypass has been refined and perfected over the past 50 years. It does lead to improvement in diabetes, and it's also well suited for patients who have reflux. On the other hand, the disadvantages of the gastric bypass, it is a more complex procedure. It is associated with vitamin and mineral deficiencies, as well as risk of dumping syndrome. Dumping syndrome is really intolerance to refined sugars, where you can get sick with that, including nausea, vomiting, diarrhea, abdominal pain. And you also have the risk of stomach ulcers. The Roux gastric bypass is 3 to 5 times, is associated with 3 to 5 times more complications than with the gastric sleeve. So what about the SADI? SADI stands for single anastomosis duodenal-ileal bypass, in addition to a sleeve, so it goes for SADI-S. This is a newer procedure which was endorsed by our bariatric society. It is composed of 2 parts. There is the first portion is a sleeve, basically, exactly shaped like a sleeve. And in addition to that, we have an intestinal bypass. So it's really in between the gastric bypass and the sleeve gastrectomy. The operation will cause you to be more full. It will decrease your appetite, and it will cause malabsorption. For the weight loss, it will allow 80 to 85% of the excess weight to be lost over 1 to 2 year period. It is a minimally invasive procedure, which can be done either laparoscopic or robotic, and the stay in the hospital is 1 to 2 nights. The advantages of the SADI is that it is technically simpler and it is faster to perform than the gastric bypass. On the other hand, it is highly effective for weight loss and diabetes control. It's an excellent option for a patient who's already had a sleeve gastrectomy, for example, and is looking to lose more weight. The complication profile of the SADI is in between that of the sleeve and the gastric bypass. The disadvantages of the operation, it is a newer operation, so we do not have long-term data on it yet. It can worsen or even cause new onset reflux. And it does have an impact on metabolism, just like the gastric bypass, can include vitamin and mineral deficiency. And one particularity of it is that it can cause looser or more frequent bowel movements.
All right, so what are the outcomes? Well, when we take a look at, what's the first thing we look at? So a lot of people are looking at the weight loss, and so the graph to your right will show you what the average weight loss is when it comes to that. So when they did the this particular study, they took time 0 as the time that you had your operation. And with the green line, when it comes to surgery, you'll find that there was a rapid weight loss within the first 2 years with both procedures, and then with the sleeve gastrectomy as well as the gastric bypass later on, it started to taper off. We talked about numbers beforehand. Usually with the sleeve gastrectomy, you're looking at about a 65% excess weight loss, whereas of the gastric bypass, you're looking at about 75%. It's important to understand that there's nothing that says that you can't lose more than this. There's no guarantee that you're going to lose this. This is a majority of patients who get it. But as I said before, everyone's different. So that's goal number 1. But more importantly, the 2 more important factors that we do afterwards is to slide to the left of your screen. And it's resolution of your medical problems. If a patient comes to me and said, "Doctor, I've lost this much weight," I am happy, and I'm happy for my patient. However, more importantly, when patients come to me and say, "You know what, I just feel better. I've got more energy. I can finally do stuff that I wasn't able to do before." That's a more important goal when it comes to weight loss. We want you to be able to play basketball with your children. We want you to have more energy so you're not tired a lot. And that goes towards quality of life. And that, when they took this survey, found that to improve in 95% of patients. And then lastly, and the main reason we're doing this is to improve your risk of dying, that last slide that I talked to you about. And that's by decreasing the amount of medical problems you have or preventing you from getting those medical problems. So if you look at some of these numbers, you're looking at a resolution of, for example, sleep apnea. 74 to 98% of patients had a resolution of their sleep apnea. You take a look at diabetes, which had an 83% resolution. Women who have polycystic ovarian syndrome had a almost 80% resolution of the facial hair, and they had a regular cycle after the surgery. You look at hypertension, which also had a very good response when it comes to surgery. And that's the real reason we're doing this. The reason we're doing this, keep in mind, we're not plastic surgeons. We're doing this to improve your health. And so there are things that we're going to ask you to do to help you improve your health. We're going to ask you to walk. We're going to ask you to try and quit smoking. There's no need for us to try and improve your health if you're taking those years away by smoking. Every procedure that we do has a possibility of complications. It's important to understand that the risk of complications are low with the surgery. However, they're not 0. With any kind of operation, we worry about bleeding, infection. Patients who get this operation tolerate it differently. There are certain patients who just have nausea and vomiting. And if you do get this, we will do whatever we can to try and find out what it is and fix it. There's always a chance of a leak whenever we sew 2 things together. There's always a chance of having a gap in the staple line causing a leak. And that's very, very rare that happens, but it's not 0. It's not a possibility. It is a possibility. We talked about reflux as being one of the big things that we look for. It can be of a variety of degrees. It can be very rare, and the key is to get the right operation beforehand. It's usually minor where we just have to give you medication, but it can be severe enough that we have to do something more. We do ask you to walk immediately after the surgery, and that's to make sure we prevent blood clots from forming in your legs. And then there is still a chance of vitamin deficiency, although it's not as bad as it is with the gastric bypass. Excess skin. A majority of the patients who I see develop excess skin. We can talk about things that you can do afterwards, such as getting a tummy tuck afterwards once you finish your weight loss journey. But that's something we can talk to you more about in the office.
The complications associated with gastric bypass are risks associated with any surgery, including death. Over here, I want to talk about dumping, which is intolerance to sugar. As I mentioned, we have the risk of vitamin deficiencies, which can be lifelong because of the malabsorption. And we have the risk of blood clots. And so this is why ambulation is also so important after surgery. The complications related to the SADI include the risks associated with any surgery, including death. And those are the complications listed: infection, nausea, vomiting, etc. As mentioned, the particularity of the SADI is a possibility of looser bowel movements and mineral and vitamin deficiencies. In terms of the choice of the operation, which one should I have? Sleeve, bypass, or SADI? Well, it's really your decision. Each procedure has a risk and benefit profile, and we will support your decision unless there is a medical contraindication to your choice, at which time we would like to steer you in a different direction.
All right, so next we're going to hear from our nurse practitioner, Danielle Robbins, who's going to help you from the preoperative workup standpoint. She's going to let you know what to do in order to try and get the surgery, as well as what you may be looking at prior to your actual procedure.
I'm the clinical coordinator and nurse practitioner with the Lawrence Hospital Bariatric Program. I'm going to walk you through some of the steps we have before having bariatric surgery with us. So after today, you've completed the seminar, which is step 1. Next, you're welcome to call our office and schedule a consultation with one of our bariatric surgeons. After this, you'll begin working with Lucrecia, our dietitian, and I will provide education and support to help navigate the program and how to have success after surgery. You'll also begin an extensive preoperative workup. Each patient is given a preoperative workup by their surgeon. This includes getting clearance by a cardiologist, a gastroenterologist, etc. Each doctor will examine you and ensure that you're medically optimized to undergo general anesthesia. My role as coordinator, I will help you through this process and gather your results as they come in, and I'll review them with you. Once you complete your workup, you'll see your surgeon again for a visit to select a surgery date, and you can ask any additional questions you may have. You'll begin a pre-surgery diet that our dietitian and I will review with you. And then after surgery, our team will work with you closely in order to monitor you and promote healthy weight loss. Thank you for watching this seminar, and I look forward to helping you reach your goals.